So obesity and why treating weight protects more than the scale is our topic of discussion or the presentation. And I would really like to thank and acknowledge our session partner, Novo Nordisk, for this. And to guide us through this vital conversation, I would like to welcome Dr. Peeyush Jain, Director, Non-Invasive Cardiology, Fortis Escort Hospital, for this presentation. Can we have you on stage, sir? And let's welcome him with a round of applause.
So, in the last session, a question was raised about how do you react to new approaches to diagnosis and management. And we got a very good answer from the perspective of an administrator. But from a doctor's perspective, whenever there is something new, it generates a lot of excitement, and there is no doubt about it, because medicine is not perfect and it is always changing. At the same time, there are a lot of questions also in our mind, and that is nothing but a healthy skepticism. Because if we don't question, then probably we will be accepting things too easily, and that's not a good thing for the practice of medicine. So today I'm going to talk about a relatively new treatment for obesity and overweight management, particularly in high-risk patients. And if you go historically, you find that obesity management is basically a forte of people who advise lifestyle management. That is more or less, you could say, that is not very effective, because a very healthy lifestyle is very difficult to follow, and it can't be followed up by most of the patients for the whole life. And relapses are important, factors in the natural history of obesity. You find weight cycling, weight decreases, increases again, and there are, instances of yo-yo dieting, and you find that people are taking this diet and that diet, and all these diets actually basically are actually not very effective once a person becomes overweight or obese. However, weight reduction is very, very important for reducing the risk of several disorders. About 200 disorders of the human body have been implicated with the occurrence of obesity. So, it is not only a question of reducing the weight and looking healthy and dashing, but also it is very important from the point of view of reducing the occurrence of disease. That is number one. And secondly, when the disease attributed to obesity, at least in part, has happened, then risk reduction of future adverse events that could lead to hospitalization and maybe even premature death, that also is very important. So I was talking about the historical failure of the drugs like sibutramine, rimonabant, lorcaserin, and some drugs which are still used in day-to-day clinical practice, but not very often because of their side effects and their unsuitability for most of the people. So at last we have one drug or maybe two drugs recently which have shown a great promise in not only reducing the weight significantly, but also in reducing the risk of metabolic diseases like diabetes mellitus and cardiovascular disease. So let me just, with this introduction, go forward, and this is my financial disclosure. And I must say that this need not be emphasized here because it will waste a lot of time. But there are millions of people who are suffering from cardiovascular disease in India. And if you look at the people who have heart disease, you find heart disease is responsible for about 30% of the total deaths in this country at this time. And it not only reduces the risk of death, but it also takes away a lot of days of useful work, as it is known in medical language, disability adjusted life years. So people waste a lot of years of their lives because of these chronic diseases like cardiovascular disease. Now, there was a time when doctors as such were not very keen to make a diagnosis of obesity. And the reason could be many, but one of the reasons is that there was no worthwhile treatment that a doctor could actually give to the patients for weight reduction. But looking at the trends, you find that obesity incidence and prevalence has been increasing markedly, not only in countries like China, but also in a country like India, and you find that almost 250 million adults in this country have got generalized obesity, and 351 million people have got abdominal obesity, meaning thereby the preferential deposition of fat in the abdomen, which is metabolically more active and more deleterious. So, obese people, they live less, no doubt about it. Their average life expectancy is reduced by about 10 years, and 70% of these deaths are related to overweight or obesity. So, 70% of the deaths related to overweight or obesity are due to cardiovascular disease. So, the question that could be asked is, if there is a patient who has got cardiovascular disease, who is overweight, who is obese, will there be some benefit in reducing the weight? The answer seems to be yes. But before I do that, let me just say that it is not because obesity leads to diabetes or hypertension that leads to cardiovascular disease, but it is basically something which is beyond the occurrence of cardiovascular disease. Diabetes and other metabolic disturbances, and in addition to that, several other factors which lead to heart disease, cerebrovascular disease, and also heart failure. And this is independent of those factors. And more the number of metabolic abnormalities in any given category of patients, obese, overweight, normal weight, you find more the number of metabolic abnormalities, higher is the risk of coronary heart disease, higher is the risk of strokes, and also higher is the risk of heart failure. And what is commonly not appreciated is that obesity is not only responsible for coronary heart disease and cerebrovascular disease, meaning thereby stroke, it also increases the risk of heart failure tremendously. And this risk is shows a lot of increment as the number of the metabolic risk factors are added. Meaning thereby, if there are no metabolic risk factors like diabetes, the risk is relatively low, but it is not like a person with normal weight, as you can see in this graph and these arrows. If the person also has diabetes, the risk increases further. If you have other metabolic abnormalities, the risk increases further. If you also have severe fatty liver, the risk increases further. And this is true not only for coronary artery disease and cerebrovascular disease and heart failure, but other endpoints also, like some rhythm disturbances of the heart. The next point that I want to make here very quickly is that there is nothing like a healthy weight. If the weight is excessive, it is actually unhealthy. There is no doubt that there are, fatty tissue or the fat accumulating in the body, which is not so metabolically deleterious. The other one is highly metabolically deleterious, but it is just a question of gradations. As you can see in these figures, so-called metabolically healthy obesity, roughly speaking, which means there is a generalized obesity and the person does not have abdominal obesity, there is still about 38% increase in the risk of cardiovascular disease, and also about 65% increase in the risk of heart failure. This may be slightly less as compared to metabolically unhealthy obesity, which increase the risk of these endpoints by 2 times, which is slightly less than what you will say about so-called metabolically healthy obesity, but there is nothing like healthy obesity. So weight loss does improve the traditional risk factors, no doubt, but weight loss is difficult to achieve and sustain. And so far, weight loss has not been an effective strategy for cardiovascular risk reduction, except for one kind of treatment, that is bariatric surgery-induced weight loss, which is hardly ever accepted by the patients. But of course, it is effective. So, saying a little bit about what were the older drugs and why they haven't given up. Sibutramine was something that came with a big bang, but it, instead of reducing the cardiovascular risk, it increased the cardiovascular risk. Rimonabant led to psychiatric disorders. Lorcaserin led to increase in the risk of cancers. And bupropion, well, it is something that is very difficult to use in several subset of patients, like those who have got seizure disorders, uncontrolled hypertension, eating disorders, concomitant severe liver or kidney disease. So there are very few drugs actually still approved for the management of obesity, and one of them is semaglutide, which has come in a big way. So we will talk about it, and these are some of the limitations of some of these drugs, which have been largely given up for the management of obesity as far as the medical treatment is concerned. So there was a very recent trial called SELECT trial, which was performed in 17,604 patients from more than 40 countries with a 40 months of follow-up, and part of it was also conducted in India, where there were about 500 participants from India. So what were the ways in which this trial was conducted? It was conducted with a drug called semaglutide, which is a GLP-1 receptor agonist, injectable form, marketed as Wegovy, and this was compared with something called placebo, which is basically not a drug but looks like a drug to the patient. And we also don't know when we are conducting that trial. Only those who have supplied these medications, Wegovy and placebo, will know which is the drug that is there in the pill that is going to be not the pill but injection, which is going to be administered to them. So overweight or obese patients with established heart disease and no previous history of diabetes. Very important, because Wegovy, not Wegovy, but semaglutide actually I should say, is also indicated for management of diabetes. But here the patients were not having diabetes, and they were given Wegovy 2.4 versus placebo, and they were followed up for about 40 months on a median. So they looked into first occurrence of cardiovascular death, non-fatal MI, and non-fatal stroke as a combined endpoint, with certain secondary endpoints. I will not bore you with the different, details of this. And these were the demographics of these patients. 72% were male. The mean age was 61 years. 8.2% were Asians. 84% were white Americans. And 67% patient had myocardial infarction in the past. 17% patient had a stroke in the past, and 8.2% had more than these endpoints, regarding the cardiovascular endpoints. So they were not diabetic, but there were about 66% of these patients were pre-diabetics. Between normal and diabetics, there is a state called pre-diabetes, and their mean BMI was 33. And as you can see, some of these patients were actually having a BMI of as much as more than 45. And their kidney function was relatively good, with an EGFR of 82. Importantly, about 25% of the patient had chronic heart failure, and both heart failure with preserved ejection fraction and reduced ejection fraction were there. So the treatment that was being given to them previous to administration of either semaglutide or placebo, that was very good, and good lifestyle management was also being done, and these are some of the medications that were being given. So what was the end result? That is the question. So Wegovy or injectable semaglutide 2.4 milligram, that reduces the risk of major adverse cardiovascular events by 20, and that was statistically significant. It was not a chance finding. The major benefit was reduction in the non-fatal myocardial infarction. So based on these findings, the European Society of Cardiology said that GLP-1 receptor agonist semaglutide should be considered in patients with obesity or overweight and chronic cardiovascular syndrome, meaning thereby stable coronary artery disease, without diabetes to reduce the risk of cardiovascular mortality, myocardial infarction or stroke. So this is what they said. And then the Indian CDESO, they also recommended that Wegovy 2.4 milligram should be considered to reduce the risk of major adverse cardiovascular events in adults with established cardiovascular disease and either obesity or overweight. Now the question that came to my mind immediately was it only because of weight reduction or it was something else? So here the benefit was observed very soon, that is as early as 3 months after the initiation of therapy with Wegovy, whereas maximum weight loss actually occurred at 14 months. So obviously only weight loss was not responsible for these cardiovascular benefits. So what could be responsible for this additional benefit? That actually is not known, but it is thought that it may be because of the direct GLP-1 receptor agonist action of semaglutide, because we know that the GLP-1 receptor agonist, they improve the endothelial function, they have anti-inflammatory effects, they reduce the ischemia reperfusion injury, they also improve the blood pressure, lipid profile and prevent the vascular remodeling. So it was a combination of reduction in the weight as well as a improvement in the risk factors and direct vasculoprotective effects of Wegovy. And cardiovascular death was also reduced by about 15%. I'm so sorry, somebody is bothering me. By about 15%, that was not statistically significant, but directionally it was, an improvement over what was achieved with the placebo only. So looking at the different endpoints, and I think it's basically repetition, but importantly what I would like to say is that there was also about 18% reduction in the all-cause death. The other thing that seems to be something that I need to really tell you here is that it led to a reduction in the risk of coronary revascularization. That means the patients, less patients underwent CABG or PTCA following Wegovy treatment in obese people with established stable cardiovascular disease. And then of course there was some renal benefits also, reduction in the risk of nephropathy, and what I don't see here is heart failure, but I went through the original article, and according to which the composite heart failure endpoint was also reduced by 18%. That means injectable semaglutide also reduces the risk of heart failure. Exactly what is this composite endpoint? It includes many things, but we don't know whether it led to a decrease in the heart failure hospitalization or not. So I'm just about to finish. Sorry for being very slow. So there were benefits in terms of reduction in the inflammatory markers, weight, waist circumferences, systolic and diastolic blood pressure, some reduction in HbA1c even if the patients were not diabetic, and many of the patients who had pre-diabetes, they reversed to normal blood glucose. That means they were no more pre-diabetics, and that's a very good point here. So the key takeaways are here that this is a very large trial of 17,000 patients without diabetes and cardiovascular disease who were followed up for 40 months and found that there is a reduction in the risk of major adverse cardiovascular event by 20%, and also some heart failure benefits also. So this is a consistent benefit, and if you look at different sub-patient subgroups, young versus older and things like that, you find that this is a benefit which is consistent, which means it is not a fluke, it is basically something that is real, and we have to make a note of that and possibly change our practice of reducing the risk of myocardial infarction, particularly in patients who have cardiovascular disease, who are stable at the moment but are at the risk of getting another myocardial infarction. And this is all I have to say today. Thank you very much.
I will invite Dr. Manisha Khurana, founder for Next Edge and editor-in-chief for VOH, to please step up for a small token of our gratitude to Dr. Jain here for his wonderful presentation. Thank you, sir. And I'm sure that many of us were able to pick up key insights on the topic even more deeply. Thank you so much.